Good morning and welcome to the Senior Hour, which is sponsored by Santa Clarita In-Home Care and Advanced Audiology. I'm Barbara Cochran with my co-host, Dr. Jean Dorio, on your hometown station AM 1220 KHTS. And our guest this morning is Dr. Marwha Kelhani, a palliative care doctor. And here comes our Dr. Jean. He's a few minutes late, but we'll accept that. And so anyway, what is a palliative care doctor?
So a palliative care doctor is a physician who focuses on patients who have serious illness. These serious illnesses can range anywhere from serious types of cancer or more advanced stages of heart failure, dementia, COPD or emphysema. So it's really about dealing with patients who are having to deal with or manage pretty serious illnesses. And the nice thing about my job is that I don't just do it, as a standalone physician, but I'm really part of a team process so that we really take care of the patient and family on a whole person level. So we attend to all their physical ailments, really help with their symptoms, their pain, optimize their quality of life from the physical, but also focus on emotional, psychosocial, and spiritual support as well.
So you cover everything then?
Yes.
Because that's a tall order.
Yes, it is. And
it really is. What you have said, the number of areas that you cover.
Yeah.
It's very, very intense, isn't it?
So how, Marwha, how does a senior or the caregiver know that it's time? How do they know that it's they need palliative care, they might even go into hospice?
Yeah.
What is it that about their life? I mean, everybody will say, oh, I lived a great life. But how do you know that you're getting toward the end of life?
I think that the important thing to recognize is when a lot of stresses have occurred. And it's not just about the symptoms getting out of control, because all physicians are equipped to manage symptoms and pain. But it's really when those symptoms are exacerbated by other stressors in life, or things that are becoming more emotional or more spiritual. Why me? Why am I experiencing this? So when families or patients or caregivers are starting to feel the burden of the ailment or the serious illness, that's when we as a medical community can step up the level of care and provide this augmentation to the care that we otherwise provide.
So a lot of our seniors, they go to the hospital, they're admitted with pneumonia or some other problem that in the past had been, maybe would end up taking their life. But nowadays, with the science, technology that we have, they're given a lot of hope, and they end up getting better and going home.
Yes.
When is it? How do we decide that, hey, this is it? I mean, we can't do any more. And how you have a relationship with your doctor. How do you know that there isn't something else behind what they're saying to move you out of the hospital bed or save insurance money and things like that by, saying that you're at the end of life now, that's it? How do they trust and take away their hope, but how do we trust that they are indeed at end of life?
And that's a really important point that you're making, because palliative care isn't set up to really do case management per se, in the sense that, well, let's move this patient along, in the spectrum of, the healthcare assets that are out there. But really, palliative care done in the proper form is done to to recognize that these patients have needs, to do an overall assessment and really detect if there's continued decline, is there a functional disability that can be augmented that to then make that person have a better quality of life or even increase their functionality. And the most important thing is that the palliative care team doesn't take over the case. The palliative care team is set to coordinate with the medical team. So the primary care provider, the hospitalist, the different specialists, it's really about a collaboration, not, oh, you know what, they're on palliative care now, let's just park this patient off in the corner. Absolutely not. That is not acceptable. But it's really about trying to meet the treatments to each person's individual values. So I'll give you an example. I have a patient who has lung cancer, and this patient has been really distressed by the fact that he has a lot of fluid accumulating in his lungs, so he gets short of breath pretty easily.
Yeah.
And so the usual management would be to put in a needle, drain the fluid, get this patient stabilized and send him off on his way back home to follow up with his providers and whatnot. But when our team gets involved, we have much more of an understanding of where this patient is in regards to his understanding of his illness, in regards to what needs to be done further. We've managed to help augment his care by putting in a special type of drain that can help facilitate drainage without him having to come back and forth to the hospital. But at the same time, recognize that he was also having severe back pain, and that back pain needed to be addressed as well. So you can see that there's a lot of other moving parts when you're dealing with a serious illness, where we are just putting Band-Aids down as a medical community, and we need to, get a whole person, big picture perspective.
Okay, well then how does a family or a doctor know when to call in your team? How do they do they have a 1, 2, 3, 4, 5 area where the progression of the patient gets worse?
That's a good question, because there are different spectrums,
That's the word.
in regards to, let's say, dementia, or how advanced someone's heart failure gets, or differing levels of how advanced a cancer is. And it really takes the collaboration of some good practitioners, good doctors, and nurses to recognize when a patient and family needs extra support, and also education towards where that patient actually is in that spectrum of their illness.
And especially when, as physicians, we know that the patient cannot move forward any more than we've given them in terms of the technology that we have. And certainly cancer is the most common reason people have illness that we move toward palliative care, because we haven't cured cancer yet. We're getting closer, but you mentioned heart disease, there's kidney disease, there's advanced lung disease. Certainly with liver and kidneys, you might be able to do a transplant nowadays. And that's great that technology has allowed that. But that spectrum that I see, when people have these entities and they are suffering, they are uncomfortable, they are in pain, that brings me to think maybe they now need to talk about end-of-life care, palliative care, and even hospice care.
That's right. And the nice thing about it is that palliative care can really coordinate and really follow along the path of whatever that patient is still receiving. So it doesn't change the treatment plan. So just because they're getting palliative care doesn't mean that they're not still getting all the aggressive care and treatment that they had already been getting. So they get all that added layer of support. and specialty level symptom management, in addition to all the aggressive treatments that is already planned out for them. So there's no change in that sense. Whereas when a patient then transfers onto hospice, the focus is only on the symptoms, as opposed to treating anything aggressively, like, curing infections or chemotherapies for cancer, things like that. So there's a whole difference in that treatment plan.
And with my patients, when you're 30 years old, you have a lot of options in terms of
Yes.
your care.
Yeah.
As you get older, the options diminish. Instead of 10 possibilities and treatments, you might have 5, and you might get down to 3, 2, or 1. And, that's when, for my patients, I start looking and talking to them about, what that end of life is close. And, that's part of the problem right now with many physicians, because they have 15 minutes at the most to talk to you.
Exactly.
And they're going to talk to you about your medical problems, your medication, things like that. They're not going to talk about social issues that are going on, that you might be depressed, or you might fear homelessness and things like that. They will not go into that. So certainly they're not going to go into end of life and the potential. You've been falling a lot and you're in pain more, and we're maximize your hypertension medication, things like that are out there that we as physicians we start to look at and say, okay, be aware, but have that discussion with our patients. I'm just still not sure whether, even though it's written about a lot, and there's meetings at the senior center all the time, but, our seniors hear about it in these discussions and not from their doctor. And
that's a
I
big
think
problem.
doctors are getting better educated on this, but even with that education, sometimes the personality doesn't fit to have that discussion. Sometimes there's fear on the doctor's side. And sometimes, there's some people that just don't want to talk about end-of-life care. And doesn't that become a problem? And it's going both ways with the caregiver and the patient, and also the doctor and the medical professionals who are dealing with this.
Yeah. And the sad part about that is when you don't prepare a patient and family, it's really a disservice to them, because their amount of stress and anxiety just escalates to a whole nother level. But if you kind of piecemeal it and do it in little chunks. My nurse Leah calls it planting seeds, if you will.
Yeah.
And then putting little bits of Miracle Grow.
That's a good analogy.
Yes.
It really is.
Yeah.
Because it makes a lot of sense.
Yeah. Yeah. And so it's really about, it's getting this patient and family prepared. Well, things are kind of moving along, or, we're hitting a few roadblocks. There's more speed bumps along the way in regards to how things are going, or the treatments are just not working as well as they used to. Those little statements can make a big impact. And hearing it directly from their primary care team or other care providers on their medical team really make a big impact.
Do you think that 2017, we went to medical school, decades ago, and,
Yep.
we, had a different viewpoint of how medicine is and should be practiced. Nowadays, it is different. It's let's get things done real quick. Let's get you in out of the hospital. Let's get you into that room, and you can't put a gown on. We don't have enough time. Oh, we'll talk about the next time. Come back in 2 weeks. This is what they're hearing, and I think for us in the medical profession now, we're in a certain way worried that our patients are not getting the care that they should be getting and that we thought we would be giving them, and that's the way the system is. I wonder how other countries are handling this, because I really don't know. I know in terms of medical care to certain degrees, countries are handling them in different ways, but end of life care, I don't know. I just know that, the life expectancy in our country after 23 years of consecutively going up. Last year in October, the CDC came out and said it's gone down. And I wrote an article about 6 months before, and I stated that, that was going to happen, and indeed it did. And, once I republished it, it went national, and, people said, yeah, what is the reason? And I claimed that it was how we were looking at taking care of our patients, and sometimes quickly saying, we can't do anything more, see you later. And, maybe that's part of the horror stories that people that we're hearing in the news now that we should talk about.
Well, it's interesting, and I got the high sign that we need to take a break. So let's continue the conversation after we come back. I'm Barbara Cochran with my co-host, Dr. Jean Dorio, on your hometown station, AM 1220 KHTS.